Hello, I'm Lucy Mailing and I'm an ST7 in trauma and orthopedics, ATLS and pelvic fractures. ATLS stands for Advanced Trauma Life Support. It is one structured, reliable method for the immediate management of trauma patients. It was devised in the 1970s by James Steiner, an American orthopedic surgeon, after he crashed his own light aircraft with his family on board somewhere in rural Nebraska. His wife died, and 3 of his 4 children sustained serious injuries. He found that the local hospital was way out of its depth and provided his family inadequate basic trauma care. He said, "When I can provide better care in the field with limited resources than what my children and I received at the primary care facility, there is something wrong with the system, and the system has to be changed." And that's what he did. And now ATLS is a global language for trauma care. Why is it important? Because trauma patients die. And they die at 3 peak times after injury. Firstly, within minutes from the severity of the initial trauma. Secondly, within hours or days from hypoxia, shock, or neurologic injury. And this is the window of death that ATLS is designed to avoid. Finally, patients can die days or weeks down the line from sepsis and multi-organ failure. I'll take you through the primary survey, that is the rapid initial assessment seeking and treating life-threatening injuries. A stands for Airway and C-spine control, so it's a little bit awkward, A plus C. From the moment you approach the patient, you must maintain restriction of cervical spinal motion, or ROXM, as it is now called. This means holding the head still with both hands so the neck does not move. When you have help, you can replace your hands with a collar, blocks, and tape. All 3 are required to consider the C-spine restricted. Assess the airway. The simplest way is to talk to the patient. If they reply with a sensible answer, then they have an airway, they are breathing, and their circulation is perfusing their brain adequately. But when the patient doesn't reply, you can look, listen, and feel for air movement. At a basic level, the airway can be opened by performing simple maneuvers, such as a chin lift or a jaw thrust. But a chin lift involves extending the patient's neck, which is not allowed in ROXM. So the only manual maneuver you can do is a jaw thrust. Conscious patients don't like this, but unconscious ones won't mind. If you're stuck performing a jaw thrust, then you can't move on to assess the rest of the patients because your hands are tied up. And that's where the simple adjuncts come in: nasopharyngeal or oropharyngeal airways. These are generally only tolerated by unconscious patients. Never forget to apply 15 litres of oxygen via a non-rebreathe mask. Even if the patient is known to have COPD, they are more likely to die from hypoxia in the acute setting. B stands for breathing. Perform an examination of the chest, inspecting, palpating, percussing, and auscultating for signs of respiratory distress. There are a number of life-threatening emergencies which can be picked up from this examination and are generally treated as soon as they're found, if they can be. These are the life-threatening conditions: airway obstruction, as we've already seen, tracheobronchial tree injury, which does need specialist airway management, i.e. an anaesthetist, and probably a cardiothoracic surgeon. Tension pneumothorax. This is a B problem that you can solve. It's treated with a large bore cannula inserted into the pleural cavity. In adults, we use the 5th intercostal space just anterior to the mid-axillary line. This is a recent change. In children, we still use the 2nd intercostal space in the mid-clavicular line. An open pneumothorax is treated with a 3-sided occlusive dressing, such that the 4th side acts as a valve, allowing air to escape from the pleural cavity on expiration, but closing off during inspiration. Those are the 2 main B problems that you can solve. The rest of the list of life-threatening conditions includes massive hemothorax. This is a circulatory problem, which then becomes a breathing problem. The treatment is to drain the blood using a chest drain, which is inserted again in the 5th intercostal space. Because it's a C problem, it's essential to get IV access beforehand, as they may suddenly lose a lot of blood. Traumatic circulatory arrest, which is treated with CPR and advanced life support. And cardiac tamponade, which is treated with pericardiocentesis, or aspiration of blood from the pericardial sac. It takes a brave person to do this, and I've not seen it myself. Circulation. Examine the circulatory system for signs of shock. Shock is the inability of the cardiovascular system to perfuse end organs. It can be classified into different causes. These include hypovolemic, distributive, such as sepsis, anaphylaxis, and neurogenic causes, obstructive shock, which is seen in cardiac tamponade, and cardiogenic shock, which is seen in dysrhythmias. In ATLS, all shock is presumed to be hypovolemic, caused by hemorrhage, until proven otherwise. So where do we lose blood? On the floor and for more. That is, open wounds bleeding out, or bleeding into one of the body cavities, the chest, the abdomen, the pelvis, or the long bones. Note that the cranium is not one of these sites, although intracranial bleeding is bad for different reasons. Hemorrhagic shock can be quantified using this table. I remember it like a game of tennis. Class 1 shock equates to the loss of up to 15% of the patient's total circulating volume. Class 2 up to 30%, Class 3 up to 40%, and Class 4 is beyond 40%. The treatment of hemorrhagic shock is initially to turn off the tap. External bleeding may be controlled with direct pressure or the use of a tourniquet. For suspected pelvic injuries, we apply a pelvic binder to reduce the pelvic volume and therefore stem the bleeding. Note that a pelvic binder is a hemostatic device and not an orthopedic device. So you are allowed to use it on any fracture type. Its role is to control life-threatening bleeding, not to reduce fractures. Sometimes interventional radiology or surgery may be required to stop the bleeding. One can assess this by the patient's response to resuscitation. This table is not entirely accurate because ATLS recommends that the majority of shocked patients will require blood products transfused. A single 1 litre fluid challenge may be started first, but remember that the oxygen carrying capacity of saline is 0, so blood loss should really be replaced with blood. Disability. This one is sometimes badly performed, but it's actually one of the easier ones to assess. We're looking for signs of neurological disturbance. The Glasgow Coma score, seen here on the right, gives an evaluation of conscious level. A GCS of 8 or less is a high risk of airway compromise. We assess the pupils for size and reactivity, and then we check for lateralizing signs. This is as simple as, are they moving all 4 limbs? Check the patient's glucose. Some say that ATLS can be remembered as ABC, DEFG, standing for don't ever forget glucose. Exposure and environmental control. Fully expose the patient to examine all areas and make sure you don't miss anything, but do keep them warm. Hypothermia forms part of the lethal triad, along with acidosis and coagulopathy. Following any intervention, it's crucial to return to the beginning and repeat the primary survey from A to E. After completing the primary survey, one can move on to the secondary survey, which is a head-to-toe examination looking at all body systems for any other non-life-threatening injuries. At a later stage, the secondary survey can be repeated and is now called the tertiary survey. It again serves to find any injuries which may have been overlooked during the initial distracting injuries. Just a couple of slides finally on pelvic fractures. This is a simplified Young and Burgess classification of 3 main fracture patterns. On the left, these 2 show lateral compression, where the patient has had an impact from the side and part of the pelvis has been compressed inwards. These may be stable or unstable. Open book or antero-posterior compression type. Here, the force has been directed in the AP plane. For example, a motorcyclist in an accident striking the front of their bike. And finally, vertical shear. These are the fall from height type of fractures. The hemipelvis has sheared upwards. And these are generally considered to be the most severe injuries. Pelvic fractures may be stable, rotationally unstable, and or vertically unstable. They all have the capacity to bleed. Vertical shear and open book injuries are the worst for this. Typically, it's venous bleeding from the retroperitoneal pelvic plexuses, which are very fragile. And it is this bleeding which accounts for the mortality rate of over 10%. The initial treatment of pelvic fractures is therefore to stop the bleeding and resuscitate the patient using ATLS principles. Further guidance on management of pelvic fractures can be found on the British Orthopaedic Association Standards for Trauma website. The definitive management of pelvic fractures should be in a major trauma centre or one with pelvic expertise. To conclude, ATLS is one structured and reliable method for the assessment and treatment of the acute trauma patient. It follows a logical A to E approach, and one must remember to reassess the patient after each intervention. Thank you.